All right. Hi, everyone. This is Liz Finkelman. Welcome back to the Action Collaborative's virtual symposium. Our next session will focus on moving away from a treatment-only approach, accelerating evidence-based OUD prevention practices. So treatment has been a major focus in addressing the opioid crisis, but experts are turning to prevention strategies in hopes of earlier and more effective interventions. And so I'm delighted to introduce this panel of experts who will discuss strategies and promising opportunities to prevent opioid and other substance use disorders that span clinical care, social and community-based services, policy, and practice. The session will be moderated by Alonzo Plough, who is Chief Science Officer at the Robert Wood Johnson Foundation. And joining Dr. Plough are Dr. Elizabeth Salisbury-Afshar, who is Director of the Center for Addiction Research and Effective Solutions at the American Institutes for Research, Dr. Marcus Plescia, who is Chief Medical Officer at the Association of State and Territorial Health Officials, Dr. Helena Hansen, who is an Associate Professor in the Department of Psychiatry at NYU Grossman School of Medicine, and Mr. Devin Reeves, who is Executive Director of the Pennsylvania Harm Reduction Coalition. Their full biographies are available on the event website for you to access, and please note that we will be taking questions from the webinar audience during the last 10 minutes of the session. Please use the Q&A box on your screen to enter a question. And now I will turn things over to Dr. Plough. Thank you.
Great. Thank you, Liz, and good afternoon and late morning on the West Coast to all the people listening. I'm going to just frame a little bit of what's going to be a very exciting set of presentations by the panelists. And I'm going to think a little bit about this being as moving toward a prevention approach, rather than just exclusively away from a treatment only. I think part of what we want to come out today is an imperative for prevention with a clear understanding that is connecting prevention to treatment, but trying to really think about how we can maximize the opportunities that are currently missed around prevention in opioid use disorder or substance use disorder in general. I always turn to the writings and thinking of a particular social epidemiologist, Nancy Krieger at Harvard, when I think about the challenges ahead of us. And some of you know Nancy talks about getting to the causes of the causes. And those are the things that are prior to the manifestations of social determinants. What is it that makes housing poor? What is it that makes populations marginalized? What is it that creates those life conditions that provide for or set the stage for unequal life outcomes? So it's very important as we talk today, and you will see it through all the presentations, understanding the social determinants, what is the causal nexus there, what are the possibilities for the earliest intervention along this pathway. And it's complex, but it actually is a pathway that we need to understand, and it also involves a different kind of both transdisciplinary and multi-sectoral approach. And as we go through what the speakers are going to present and the discussion, I hope we aren't scared away from the fact that most of us aren't trained and most of our institutions aren't aligned to do the kind of prevention we're talking about today, but hopefully this will be a guide to what that looks like so we can think about these broad shifts, these life conditions, these social determinants of health, as we see in also driven in COVID, and I'm sure we'll come back to COVID a lot today, are responsible for the differences in mortality, difference in outcome, difference in prevalence that we see related to race and income. So a variety of isms influence these social determinants, and we need to consider that as we talk about this today. Some of the things that I think a prevention frame lets us think about is, what are the early precursors and understanding of cultures of despair, whether they occur in urban or rural areas? How can we, what are better indicators before that is manifested clinically in addiction or other problems? How do we think about well-being in an earlier way as part of the prevention pathway? What do we do to drive our intervention systems toward those earlier intervention points before you get to an early stage clinical or diagnostic threshold? That's sort of the essence of moving to a prevention frame. And the social determinants thinking that you'll see is very much a part, and many of the panelists are talking about the way we think about levels of prevention, stages of prevention, and the role of social determinants and the role of other factors that marginalize populations who get worse outcomes than are fair and just given those conditions. I'll end this framing with a little heads up and maybe a spoiler alert on a special issue coming out on from Health Services Research that relates to a year-long project the foundation has done with a number of researchers around the country on rethinking how we capture graphically the social determinants of health and think about it. So I would hope you all will look at Health Services Research when it comes out, but here's the spoiler alert. As you look at it, major question is it a pie chart? Maybe, maybe not. If it is, but things have changed since that wonderful baseline work on nearly 25 years ago. Role of genetics, as we're thinking, a little less. This is before people thought about epigenetics, right? So probably less in genetics. Probably smaller role of behavior, as we see behavior as a correlate of social conditions and opportunities. Probably a larger role in understanding these social conditions, a larger role in understanding environment, broadly defined, and actually a larger role than that pie chart shows for healthcare, particularly in terms of access, unequal access, lack of health insurance, and how that becomes a social determinant of health. So with that, just to kind of kick it off, we have a great panel, wonderful information that they're presenting. So we will start out just in the sequence you see on your slide. So Elizabeth, I am turning it over to you. And I'm gonna hope everybody kind of stays within reasonable confidence intervals in their allotted time. Elizabeth.
Thanks so much. So I did just want to give a disclaimer that I'm an addiction specialist and family doc and public health doc, and I kept looking at the title of this and just thinking like it feels, although I've worked a lot of my career in public health, also just want to acknowledge that although the title says we're moving away from a treatment-only approach, that I don't think any of us are suggesting that we're moving away from treatment as part of our approach. I spend a lot of time sort of focusing on expansion of access to treatment, and just want to be clear up front that I think it's still an important part of the bigger picture, but definitely not the only part. Next slide, please. I think I was largely invited to sit on this panel because I am an Action Collaborative member in the Prevention, Treatment, and Recovery group, and we've been working on a white paper that focuses on how to apply this prevention framework or the levels of prevention to opioids and opioid use disorder. And I just wanted to spend a minute or two sort of describing what it is in case people aren't familiar, and then talking a little bit about where some of our conversations have been thus far. We had hoped to have the paper ready by now, but probably not surprising to many on this group, COVID kind of put us, you know, realign some of our priorities, unfortunately, and we will get there. But so the levels of prevention framework really uses the point at which someone develops a chronic disease or condition as sort of a central point of the model. So any interventions that are focused on preventing the onset of that disease or health condition are considered primary prevention. So in the case of type 2 diabetes, this would include things like maintaining a healthy body mass index, you know, exercise, healthy diet, etc. Secondary prevention are interventions that are aimed at identifying that disease or condition early, so often things like screening tests, and then initiating treatment of that disease or condition as early as possible, ideally even before people have developed symptoms or before their disease has progressed. So in the case of type 2 diabetes, this would include things like annual screenings and early initiation of treatments. And then tertiary prevention includes interventions aimed at mitigating negative consequences and sequelae of that condition. And so one of the things that I think was really striking for me as we started having this discussion about how we apply this framework in the opioid space, there are a few things. So one, when we talk about prevention around substance use, so often our focus is solely on preventing initiation of use. And we actually had quite a few conversations about what fell into that category of primary prevention. Was it only prevention of any opioid use, or was it also prevention of the development of a use disorder? Next slide, please. And so, you know, I think that when we think about the war on drugs and a lot of the framing that's happened in our country about people who use drugs, you know, it's often sort of this assumption that anyone who uses heroin anyone who uses illicit substances is going to develop an addiction, and that all people who use drugs are bad and all drug use is bad. And so one of the things we spend a lot of time talking about is that primary prevention should include not only working to reduce the chances that someone initiates drug use, but also work to reduce the chance that someone who does initiate drug use goes on to develop a use disorder. And so often when I give talks to medical providers or even lay audiences, I spend a lot of time sort of talking about and reminding people that many people use drugs and alcohol. And in fact, the majority of people who use drugs and alcohol do not go on to develop a substance use disorder. And we know that there are certain factors that are protective and certain factors that increase risk for the development of that use disorder. And this is definitely an oversimplified visual, but I think just to give us a sense, so we know that there is a genetic predisposition that can increase the risk that someone develops a use disorder. This has probably been best studied in the case of alcohol use disorder, where we think about 40% of the chance of the likelihood that someone develops an alcohol use disorder is based on genetic predisposition. Obviously, there are also behavioral factors that apply, because in the case of substance use disorder, you can't develop a use disorder if you've never tried that substance. And then there are many, many environmental factors that can either be protective or increase the risk that someone develops use disorder. And I've just listed a few here, and I know many of our panelists are going to be talking about additional factors today, but these include things sort of at all levels. So at the interpersonal level, at the community level, at the sort of institutional and structural level, societal level, and policy levels. So we know things like parental substance use can increase the risk that young people try substances. We know that adverse childhood experiences, for example, the more adverse childhood experiences one has, the higher risk for developing addiction. We also know that institutional and structural factors, so things like equitable educational opportunities, living wage jobs, as well as racism, can play a role in the likelihood that someone develops addiction. Next slide, please. So as we started as a group really looking at levels of prevention and interventions, specifically, using this framework, again, this isn't an exhaustive list, but I think one of the things that we found is when you look at the evidence base with regard to what actually has been shown to reduce the risk of developing addiction in the primary prevention space, it was somewhat limited, specifically for opioids. So a lot of the youth education programs have really focused on alcohol, tobacco, and marijuana. We do have some skill-based youth education programs that have been shown to reduce prescription opioid misuse, but there's very little actually looking at the transition to opioid use disorder, and also not a lot specifically looking at people who initiate use with illicit opioids, which we are seeing increasingly. There is some evidence for prescription drug monitoring programs in the primary prevention space, but it's been much more focused on, or at least the outcomes that have been found are much more focused on reducing prescription-related opioid overdose, and we've all seen the data from CDC showing that we're sort of transitioning to increasingly illicit drug-related overdoses, and so the impact that PD and PLEAS will play, I think, is evolving as we see reduced access to prescription opioids and increasing use of illicits and increasingly methamphetamine as well. When we look at secondary prevention, a strong evidence base, there's obviously been a lot of focus on increasing access to medications for opioid use disorder. We know that this is an intervention that can show pretty short-term impact. So through increasing access to medications like methadone and buprenorphine, we have seen at the population level reductions in mortality, reductions in illicit use, increases in retention and treatment, et cetera. So again, a lot of focus there, and I know I probably don't need to say more to this group about that. And then in the area of tertiary prevention, strong evidence base for syringe service programs, particularly around reducing morbidities and mortality, morbidities around HIV and Hep C transmission, as well as skin infections related to injection drug use. And then in the case of naloxone distribution, reductions in mortality at the community level. And so as we look at, sorry, I just lost connectivity, I think. So but I have my own slides pulled up. So as we'll go ahead and move to the next slide. So as we look at the levels of prevention and really start thinking more broadly about a couple of things. So one is, as Alonzo mentioned, what are the actual changes in our society and in our culture that have led to this increasing demand, as well as what are the structural factors that are going to be increasing the risk that someone develops addiction and then makes it harder for people to recovery services, as well as tertiary prevention services. It's really important that we start sort of broadening our lens. And so in the earlier years of the opioid crisis, I think there was so much focus on what are the interventions that we can implement right now that we will be able to measure and impact within the next few years, within this election cycle, if you will, and how do we implement those as quickly as possible. I think we're now finally at a stage where we can start thinking much more critically and recognizing we need to continue to do the things that we've already started with increasing access to treatment and increasing access to SSPs and but simultaneously, we need to be also asking those questions about the structural factors. So I've listed a bunch here. I am not going to go through them all in detail because I know many of my co-panelists will be describing them. But in the areas of primary prevention, I think really thinking about what are the protective factors that can be enhanced, how do we reduce risk factors like reduction in adverse childhood experiences, reducing trauma, increasing educational opportunities, housing opportunities, how do we enhance family supports and ensure access to living wage jobs. In the area of secondary prevention, we've heard a lot about stigma today, and I just want to say in working with patients with addiction, you know, I hear so often that people were afraid to step forward or to disclose or to ask for help because of the stigma, you know, in the broader society, because of fear of losing a job, because of stigma that they experience when they tell a medical provider that they have addiction, or the stigma they experience when they actually receive addiction treatment services. So a lot of work to be done in that space. Additionally, we know many people with substance use disorders have co-occurring mental health conditions. So ensuring that we have actual parity, so we have it in law, but not usually in practice with regard to access to mental health screening and treatment services, supportive housing. I had the opportunity last year to visit Portugal, where I was really impressed by the fact that they have a really comprehensive sort of support systems in place for people with addiction that includes housing for as long as someone needs it. It also includes job training and job placement programs. And I think it was just a model that, as I thought about the struggles that many of the patients I work with have, would be so immensely helpful in their lives. Finally, incarceration diversion programs, we are seeing increased uptake across the US. But increasingly, I would say in rural white communities, and it's really been only since this has been seen as more of a white disease that we've really started to have a conversation about the fact that we can't arrest our way out of the opioid crisis. And so I think it's really important, again, to acknowledge the racism that has played a role in all drug policy in the US. We know that addiction is a medical condition, and therefore I would argue that incarceration is not the right treatment, if you will, is not the right response to a medical condition. We need medical and other support services to really support people. Finally, in the area of tertiary prevention, I know Devin will be covering many of these, so I'll move through quickly. Housing first models, we do have them in the US. We do not have enough. We often have taken the stance in the US that only people who are not using drugs, only people who are abstinent deserve access to housing, deserve access to treatment, deserve access to jobs. And I think that this has been the wrong approach. And so we know housing first models work, we just need to fund them. Overdose prevention sites, again, I think Devin's going to talk about this. I had the opportunity to visit several programs in Canada, and I think one of the things that I brought home with me that I was most impressed by was actually the level at which the peers, the people who are actually using drugs and using those services as clients, were also employed at these programs, and the importance of job opportunities for people who are actively using drugs. And finally, safer supply is not something we talk about a lot in the US, but I also visited a heroin-assisted treatment program while I was in Vancouver, and really could see how it could be a tremendous benefit for people for whom methadone and buprenorphine specifically just haven't been the right fit. Next slide, please. So I just want to end on this slide, which is the SAMHSA model of recovery. And I think that it is such a beautiful model. And I also think it's a great recipe for prevention if we think about it in the broadest sense possible. So it focuses on health, or what I might call wellness, home, or sort of access to safe housing, a safe place to live, a sense of purpose, and it recognizes the importance of community. And so I think, you know, for me, so often when I look and talk to my patients about the factors that led them to drug use in the first place, the factors that really caused them to develop addiction and then have kept them in that cycle for so long, it always stems back to one of these four, and for many patients, unfortunately, all four of them. And so I would just encourage us all, again, to pull the lens back and think broadly about how we're addressing this moving forward.
Great. Thank you very much, Elizabeth. We'll move to our next speaker, Marcus.
Great. Thanks, Alonzo. Okay. So hello, everybody. I'm really pleased to be here and have a chance to present to the committee. Sorry I can't be in person, but I guess virtual is the new normal for us. So I'm with, if I could have the next slide. I'm here representing the Association of State and Territorial Health Officials. This is just a quick slide that describes the work we do in our membership. We basically represent the state public health leaders in every state and in the U.S. territories. And then we also represent the staff of each and every state and territorial health agency, which is a workforce of about 100,000 people. Next slide. This particular topic, moving beyond treatment, moving away from or beyond treatment-only approaches to the opioid situation, is one that we've been very, very interested in ASTO for quite some time now, because our membership and our workforce is so focused on prevention, the different levels of prevention. And so I put up a slide here just to give a little bit of background. This is a commentary that Mike Frazier, our CEO, and I wrote about a year ago in the American Journal of Public Health, really sort of urging along this very theme that we need to continue to be very attentive to treatment approaches to opioids, but we really need to find ways to move beyond that and look at ways we can prevent this in the first place. We actually used a framework in this commentary that was a framework that was developed by the Institute of Medicine a few years earlier, looking at different approaches to prevention. And we used a framework of looking at universal approaches, selective approaches, and individual approaches. Indicated approaches. And I just want to speak to that a few minutes. In the commentary, we talked a little bit about universal approaches, which are really societal interventions that try to deal with many of the social problems that are clearly an underlying cause for addiction. And we actually cite in the commentary the work of the Trust for America's Health, setting out a national resilience strategy, which we think has some very good suggestions of how to approach those things in communities and has a very strong evidence base. On the other end of that spectrum of prevention, indicated interventions, we discuss, among other things, prescription drug monitoring programs. So the idea with an indicated intervention is you want to identify people who are maybe in an early stage of experimenting with or using drugs or alcohol and intervene at that point before they develop a significant addiction. And we felt that prescription drug monitoring programs were a good example of that. And then sort of in the middle are selective interventions, interventions that are aimed at groups or groups that are at greatest risk. And one of the examples that we used for selective interventions is ACEs, adverse conditions, adverse childhood experiences. And that's what I'm going to speak a little bit about. Since then, we've had the opportunity at ASTO to do actually quite a bit more work trying to explore, particularly how state public health departments can work on beginning to impact ACEs. And I'm going to spend the rest of my presentation just giving you a specific example of something that we're doing. But I did want to start off with this context. I've also given a link to this article if you're interested. We did make it open access so that people could have availability of it. Next slide, please. So I think that people are, and if you could hit the slide again, I think that'll pull up the pyramid. Yeah, okay. So I think people are familiar with the concept of adverse childhood experiences. These are basically harmful events that occur during formative years. And you see that they sort of fall in a continuum. There are certain things that can set up a greater likelihood for children to have adverse experiences. But then you see as you go up the pyramid, there are so many outcomes that are of importance to us. And the next slide. This next slide, if you can see the individual boxes, really puts this in the context of health and public health. And you see the wide range of things where there's been clearly an evidence-based link between adverse childhood experiences and various health or public health outcomes, one of those being alcohol and drug addiction. Next slide. So we've had the opportunity to begin to try to really explore and work on adverse childhood experiences and what kind of portfolio there is in states through some funding that we have from the Centers for Disease Control. And I think this is important because there's a great deal of research and evidence-based around how important adverse childhood experiences are, but how you actually approach that and put things into practice that can impact those experiences or help mitigate those experiences is what we wanted to explore and what we think is an important role for state and territorial health departments. And so our platform of work really runs across three areas that I'm going to talk about each one briefly. We've started something called an ACEs learning community. We've done a legislative scan looking at some of the policies in state governments that can be impactful around ACEs. And then we've done a capacity assessment tool, a survey of our membership to get a sense of what state public health departments are doing in this area, who's doing it, what kind of work is going on, and what kind of capacity are we seeing having in place. I don't have a slide about the ACEs learning community, so just a couple of things about that. Learning communities are a very common intervention for us at ASTO. We convene a group of states. Often they're early adopters on a particular area. And then we really create a very collaborative experience where states can share best practices amongst each other. And out of that, we're also able to pull away some of those best practices that we can ultimately share with other states who are trying to get started on a specific area. So that's we have 7 states in that collaborative now. And that's sort of an ongoing activity. Next slide, please. This slide just gives an example of some of the areas that have come to light through the Learning Collaborative we put into place. These are some of the community level interventions, the first of which is evidence-informed. The other 2 are considered to be more evidence-based. And these are things that we've seen in the 7 states in our Learning Collaborative. I think most people are quite familiar with the Nurse Family Partnership Program. That's quite widespread as far as its use in state and local public health departments. These are just a few examples of some of the other things that we've seen states experimenting as well. Next slide. We are very, very interested in policy because we represent state public health leadership. We have an opportunity to work very closely with state leaders who are capable of introducing policy or influencing other policymakers to introduce policy and have a great deal of influence around that. So as I mentioned, we've begun to try to map out what some of the different states are doing around policy that pertains to ACEs. And this is just some examples. We thought that the basic framing of the issue, as was done in Utah, was very helpful in that it lays out and provides additional credibility and visibility to the issues around ACEs. And then some very specific things that deal with some of the underlying things that set families up to experience ACEs, social conditions, and some of the interventions around livable wage, increasing minimum wage, earned income tax credits. All of these things are things that are emerging that we're seeing many states start to experiment with. And then other areas that are particularly compelling right now in the middle of the COVID epidemic, like paid leave. Next slide. So that's a little bit about our learning collaboratives and some of the policy interventions that we're seeing start to emerge in states. And now I'd like to go a little more broadly and talk about this assessment that we did across all states and territories, looking at kind of what is the capacity or infrastructure to work on ACEs in state public health departments. And you'll see in this slide, we got a 75% response rate from all of the health departments, which is quite good for one of the surveys that we fielded. And again, the objectives were really to begin to understand what the capacity in states are. Next slide, please. So some of this is pretty basic, but I would say that the work around ACEs and really a lot of the work around specific areas that are more oriented to disparity and social determinants are still getting going and becoming institutionalized in states. What we found is that most of our respondents in states who are working on ACEs type of areas are in a maternal and child health component of the state public health department. That seems to be the area that's been the most engaged in ACEs work. And then about half of respondents are spending at least half of their daily work on ACEs. So half, I mean, I don't think we had very many instances where we had full-time equivalents. So it's probably somewhere a person working half to full-time on this particular area. Next slide, please. Infrastructure capability. So, you know, in addition to having the infrastructure within the state public health department, most of the work in state health departments is done through partnership with others. And you see that here with ACEs, about 3/4 of jurisdictions are working in partnership with other parts of the public sector around issues related to ACEs. And then, interestingly, a little more than 2/3 are actually beginning to enter into public-private partnerships. Next slide. And I'll just close now by giving you a little bit of a sense of the kind of areas that we are seeing states to beginning to develop capacity. And then the next slide, I'll show you some where they're not. I broke this down in the same format that you just saw from Elizabeth, looking at primary prevention, secondary, and tertiary. So, you know, we see quite a bit of capacity being built around programs that are designed to give children a stronger start, a considerable amount around teaching various skills that can be helpful with preventing or mitigating the effects of ACEs. And then around more secondary prevention, a lot of states are now collecting information about ACEs in their behavioral risk factor surveillance survey. And a number of states are beginning to try to use those data to better coordinate and target their interventions. Quite a bit going on around behavioral health in schools. And then in the area, I'm sorry, those were tertiary, the orange are the tertiary interventions, and then the blue intervention, facilitating child and adolescent linkages to care, an area of secondary prevention. So those are some areas that we see beginning to emerge that states feel like they are beginning to have some capacity to do. And then the next slide lays out some areas where the capacity is less, some areas we think we could begin to see more development and movement. And these are where states replied that they had either no capacity or very limited capacity. So working with children who have parents in incarcerated settings, working in pediatrics around screening for ACEs and substance abuse treatment, and among young parents, and then working in juvenile justice. These are some specific areas that we're going to try to focus on, seeing how we can develop more opportunities for states. And then the final slide, one of the things that I am very proud of the work at ASTO is that, you know, in the midst of this COVID-19 epidemic that really has, you know, completely occupied our leadership. I mean, it's been very difficult to do much of anything else in a state or local health department right now because of the COVID outbreak. But early on, we put some materials out for state health department technical assistance, really trying to keep some focus on the whole issue of opioids, and particularly on the issue of adverse childhood experiences, because we're in a setting now that is just such a significant risk to see more and more of that. And so I'm not going to go into detail. I want to stay within my 5 to 7 minutes, but I did want to show this slide I think the audience has these slides as well. Both slides have a link that you can follow if you want to look at some of those specific materials that we've developed. But some of this really is try to anticipate the fact that COVID-19 is going to certainly exacerbate ACEs, and we're already beginning to see data suggesting that it's exacerbated the issues we've seen around use of opioids. So thank you very much. That concludes my presentation.
Great, thank you. Thank you very much, Marcus. Our next presenter, Helena.
Thank you so much. So I first want to make sure you can hear me.
Very well.
Okay, great.
Good. You're good and clear.
Great. I want to start by pointing out that the opioid crisis inspired the most biomedical treatment-oriented policy response to substance use in recent US history. So that's just something to bear in mind. It's a leap forward from earlier prohibitionist and drug war responses, but our enthusiasm for pharmaceuticals has not been matched by intervention on root social causes of overdose. And we paid the price, next slide, please, in accelerating overdose deaths. So this could be otherwise. France, for example, next slide, please, often held up by US treatment advocates as an exemplar of buprenorphine dissemination and of overdose prevention, has other critical components to its opioid policy that are not mentioned in the US. Foremost is a well-funded national network of coordinated community-based harm reduction and treatment centers, next slide, that offer comprehensive social services, housing assistance, peer support, as well as buprenorphine, methadone, naloxone, syringe exchange, and safe injection facilities. These centers reach low-income people and immigrants who can't easily access primary care doctors despite universal French health coverage. The centers have nimbly adapted to COVID, employing outreach workers and peers to provide mobile services and medication delivery in a coordinated national fashion. So back to the US for a moment. Early reports on the compounding effects of COVID and opioid use suggest that opioid use disorder increases the risk of COVID death, while COVID restrictions on clinics and social contact contribute to the risk of opioid overdose. So social determinants of health connect these threads, and this is a window of opportunity for us to invest in social determinants and community-based services. In the year after I first spoke with this collaborative, I've worked with members of the collaborative and additional co-authors on 2 articles about addressing structural and social determinants of opioid use disorder, and I'll share the highlights from those now. Next slide, please. In the first paper, we established parallels between opioid use disorder and COVID in terms of their social determinants and unequal death toll by socioeconomic status, race, ethnicity, and geography. We show how traditional pie charts, next slide, of percentage contributions of social determinants to outcomes, and I think Alonzo was hinting at this, next slide, are somewhat linear, next slide. While newer infographics represent a less linear, more interactive model of social determinants of health, next slide, please, that are important for showing how, for example, local economies, housing and work conditions, and healthcare access all influence each other. This sets us up for our argument that addressing social determinants of health in opioid use disorder and COVID requires a multi-level comprehensive approach because each level of intervention influences the success of other interventions. So for example, stabilizing housing and income makes clinical care more accessible and sustainable over time. We also highlight the literature on social determinants of opioid use disorder initiation and outcomes in particular. So some of those have already been mentioned by other panelists, including trauma, discrimination and stigma, punitive drug laws, next slide please, as well as post-industrial economic and neighborhood displacement leading to disrupted social networks. For a model of successful intervention on social determinants of health, next slide please, we look to AIDS activism that led to integrated peer support, social services, housing and community-based harm reduction, as well as community input into federal and state funding allocation, which dramatically lowered AIDS death rates. We then provide examples of successful opioid projects in the US that integrate social services with clinical care and draw on community-based and cultural heritage organizations to meet at-risk populations where they are, including, next slide, The Vermont Spoken Hub model, which integrates multi-specialty care with primary care in rural and urban areas, as well as social services. The criminal justice continuum of care for opioid users, and next slide. An initiative to integrate medications for opioid use disorder with Native American traditional healing practices, as well as Imani Breakthrough, a partnership of opioid providers, peers in recovery, and African American and Latinx churches to integrate community members with treatment. And we end with a call for robust state and federal funding for integration of clinical and social services, peer support, and harm reduction, but also for defining upstream policies like economic revitalization and disinvested neighborhoods and affordable housing, as well as interventions in themselves for syndemic opioid and COVID deaths. Okay, next slide, please. In the second paper, we critique the simplified reading of Ann Case and Angus Deaton's deaths of despair argument as a linear relationship between deindustrial, white, working class unemployment and overdose deaths by pointing out that life expectancy and drug use vary significantly among low-income communities. We point to the ways that media representations, next slide, of opioid overdose as, oh, I'm sorry. So this is the Ann Case and Angus Deaton paper. Next slide after that. Media representations of opioid overdose as a white problem, next slide, makes invisible its toll on Black, Latinx, and Native Americans. We historicize the role of institutional racism in US drug policies through the last century, from early 20th century prohibitionism to the war on drugs, next slide please, and contrast government responses to heroin and crack problems in urban, Black, and Latinx communities of the 1960s to 80s, framed as a crisis of crime, with government responses to opioids in white suburban and rural areas of the 2000s, framed as a crisis of public health. We provide a theoretical analysis of structural racism as a fundamental cause, next slide, of the current opioid crisis, including the ways racism has negatively affected whites who were, for example, next slide please, targeted by opioid marketers and inadequately protected by regulators who focused drug control on communities of color. We then recommend opioid interventions that address structural racism, from including communities of color in the narrative of who's affected by opioids and in the development of national and local policies on determinants of overdose, next slide, to requiring racial impact assessments of opioid-related policies. Thank you.
Thank you, Helena. Our last panelist, Devin. You're on, but you're muted.
Yeah, hi everybody. Could you make me a co-host so I can do my presentation? And Helena, that was amazing. Thank you very much. And everybody else has been awesome. All right. Here we go. Let's see. Click this button. All right. Here we go. I got it. I swear I know how to use technology. All right. Share. And I guess PowerPoint. Share. All right. Can you guys see my PowerPoint? Yeah. Is that a yes? Thumbs up? You can see it? Yeah. All right. Awesome. Hey everyone.
It's small, but I can see it.
It's small.
I think you're showing us the presenter view. I don't know if you can make it full screen. We're seeing present slide and next slide.
Oh, okay. I shared the wrong screen. All right. I'm like, we're in a time crunch and I'm messing this up. That's so bad. I'm sorry.
It's okay. Sharing. It's okay.
Here we go.
Take your time.
Big screen this, close this, minimize this, and then share my screen. How about that? How's that look? All right. Hey everyone, I'm so excited to be here. My name is Devin Reeves, and I'm the Executive Director of the Pennsylvania Harm Reduction Coalition. And probably the first thing I want to just say really clearly is I'm a person that has used a lot of drugs. I did 10 years of research, using drugs, experimenting with drugs, and that was really shaped my experience becoming a professional who really does drug policy. If you are interested in sassy tweets and Instagram memes, please follow me on social media. Here's a little bit of information about my organization. And so I explicitly want to say I often have a hard time working with academics, working with doctors, because they're walking around with their like white jackets on and just white people nonsense and in academic towers. And not everyone is like that, but that is often my perspective. So I always feel weird when I'm asked to hang out with academics, because I say things like the war on drugs is the problem. And if that's not the first thing we're saying, if you're using code words like discrimination or social determinants of health, to me, that's BS. It's white people oppressing people of color. It's people of power oppressing people of color. And then what does that look like? Well, that looks like a drastic increase in Black and brown people in jail. It looks like our prison system ballooning. When we talk about ACEs, this is what we're talking about right here. This is what drives everything. So that's where we need to start off. And if we want to fix this, we need an actual advocacy movement. Research papers are excellent. I love research papers. But if we don't have academics that are stepping out of the tower, going to their state capitals, learning how to communicate, learning how to speak everyday person, that research doesn't matter. And we also need everyday people that are passionate about substance use disorder. And at my organization, we have something called the HERO Initiative. It's about identifying people that care, educating them on how to be change agents, and then activating them. And so the war on drugs has done a lot more than just create a prison state in the state of Pennsylvania. It's also created this nation that is at risk of HIV and hepatitis C outbreak amongst people who use drugs. And if you look at this map, this is really scary. Almost the entire country is at risk of an outbreak of HIV and hepatitis C amongst people who use drugs, because we don't do a medicine first response, we do a criminal justice response. And so we think that harm reduction is the solution. And let me just push back a little bit on what Elizabeth said, though I thought everything she said was excellent. Harm reduction is its own thing. It's not prevention, it's not treatment. Harm reduction should be the big umbrella, and everything that everybody else is saying is actually underneath that, right? The broad goals of harm reduction are reduce the health, social, legal harms associated with drug use. And let me be clear, doctors, the system, hospitals are the ones oftentimes doing harm. When we have somebody who experiences an overdose at the end of the last panel, and the doctor says, well, I'm going to take you off that medicine, that is actually doing harm to the patient. It shouldn't be just about a shared decision-making process. It should be about how can I provide you information on how to reduce your risk of overdose. Harm reduction is also a social justice movement, advocating for policies and resource interventions that can meet the diverse needs of drug users and their community. And ultimately, harm reduction says you are still a human being even though you use drugs. You do not become an animal that deserves to be in a cage, which we do on wholesale, right? And so the practical harm reduction definition is harm reduction is any intervention which mitigates the risk of a dangerous behavior, right? People do silly things like jump out of perfectly good airplanes. I would jump out of an airplane if we were all going to die in a crash if I didn't get into that parachute and jump out. However, to do that under any other circumstances seems outlandish to me, right? But people do that, they think it's fun, and I'm okay for that, and I want them to have a parachute. But we don't, in whole, judge people who jump out of airplanes as somehow morally defect. And there's all these other examples of harm reduction: helmets, seatbelts, airbags, life jackets. And let's get a little bit more controversial. Condoms are a form of harm reduction, right? And we've got a lot of places in America where we don't give out condoms. We tell people, I understand you're 16 years old and you figured out that sex with self feels excellent and orgasms are awesome. However, don't do that, and then definitely don't do it with anybody else. And here's no information about how to keep yourself while doing these things. And then we also don't have conversations about what consent is. And then we're surprised when we have a rape culture. And so access to naloxone is something that feels very middle of the road. I want everyone here to know that the very first program ever to give out naloxone to people that use drugs was a harm reduction program, the Chicago Recovery Alliance, over 20 years ago. And let me tell you how upset the FDA was and the government. We're going to come in, we're going to arrest you. You can't do that. Drug users can't be trusted to save each other. Boy, were they wrong. And it took us 20 years to change the public perspective, right? And we still do dumb things with naloxone, right? There's all these myths. We need to give first responders naloxone. I can't tell you how many places in America the cops don't want to have naloxone to save people, right? We're seeing in dumb places like Indiana, the cops saying, we're not going to save people with naloxone because of COVID. Great. I'm glad we gave you this life-saving tool when you're not even going to use it. We need to flip the script. Number one, we need to focus on giving naloxone to people who use drugs. We need to make sure, number two, behind them is other bystanders. So that means if somebody in your house is using drugs, you want to make sure your loved ones have naloxone. And the least important people to have naloxone is actually summon first responders, because I can tell you as a black man in America, I'm not trying to call the cops for anything. No reason. Don't call the cops. Unless I'm going to die, I'm not calling the cops. right? And I can tell you, as a former drug user, we all mostly feel that way. We don't want to call the cops. And with the proliferation of drug delivery resulting in death charges, where cops and DAs charge people for murder, for overdoses, people are less and less likely to call 911, even though we have 911 Good Samaritan policies. This is super important for our West Coast people, where fentanyl test strips are where fentanyl is just making a new appearance, as opposed to the East Coast, where it's been there for a long time. We need to have fentanyl test strips. Seattle, Portland, San Francisco, LA. We're seeing fentanyl showing up in press pills, in black tar heroin. We need fentanyl test strips. Syringe service programs are an excellent intervention when it comes to harm reduction, and they do all these things on the left-hand side. They don't just pass out syringes, but sadly, most places in the country that need syringe service programs don't have them, right? We see here, blue states, syringe service programs are legal. Green states, they may be local legally, and red states, they're actually explicitly illegal. Now, this map is confusing. There are syringe service programs in Texas, even though it's red. The blue state of Florida, even though that whole state is blue, there are only syringe service programs in West Palm Beach, Broward, and Miami-Dade County. So the rest of that state might be red, right? And in Pennsylvania, we're green, but only in Pittsburgh and Philly do we have legal syringe service programs. And just to show that it's not like a Democrat-Republic thing, Alex Azar, the U.S. Secretary of Health and Human Services, says syringe service programs aren't necessarily the first thing that comes to mind when you think about a Republican health secretary. We're in a battle between sickness and health, life and death. And let's be clear, the reason that syringe service programs are explicitly illegal is because legislators teamed up with cops to pass paraphernalia laws where they said, we found these junkies, but they didn't have any drugs on them, so we couldn't arrest them. Let's make the shit they use drugs with illegal so we can lock them up and get them off the street. And we really say the same thing in 2020, only it's let's lock them up, put them in jail to get them treatment. And that's supposed to be better? I don't think so. Overdose prevention sites. Overdose prevention sites are amazing interventions. They work in countries all over the world. Millions of times people have used drugs in overdose prevention sites. 0 times has somebody died. However, the Trump administration thought it was worthwhile to spend time, money, and resources to try to ban the first supervised injection facility from opening up in America. We need more LEAD. We need anything that strips away the war on drugs. LEAD is awesome. Here's some information about LEAD. It's about reorienting government response. It's about improving public safety, reducing the number of people entering the criminal justice system, undoing racial disparities, sustaining, and really strengthening the intervention. And just to make it clear, Black people are getting screwed by the war on drugs, right? So we see more Black people in jail for drug crimes than we are represented in the general population. That is just not fair, right? This is racism. So anytime you are going forward talking about anything about, and again, I cannot thank Helena enough, we're centering on white people. They have the problem, they're the solution. Those solutions don't come to Black communities. And that makes us mad when we are dying at a greater rate and being impacted by a greater rate than white people. We must end the drug war for these reasons. Once you're part of it, your life is screwed. Child custody, voting rights, employment, business and student loans, occupational license, public housing assistance. And these are the basic parts that are supposed to be guaranteed you as a human being in America. Thank you.
Great.
Let me pass it back. Hold on.
Thank you. What a panel. Okay, and what a set of issues. We haven't gotten a lot. Liz says we haven't gotten a lot of questions from the audience. So I'll start with some, but I encourage you to take it any other way that you want to go on this one. But I'm going to start, since I'm the moderator, I have some privilege. So I'm going to start with how this has reconnected me to my public health practice life, which is a far longer life than this philanthropic life. And it takes me back to, starting the Syringe Exchange program in Boston when I ran Boston, and then evolving it in Seattle, King County, as Devin says, as we realized harm reduction was a rubric for all of what we were doing. But this leads me to the question around how do you bring these systems of awareness together? As a Seattle health director at a local level, I could bring the police chief and the fire chief and the EMS director together to say, don't do a dual response call, police and paramedic, when we're going to be giving out naloxone, or no one's going to call. So the issues we've talked about, ACEs, housing, I'm going to throw it out to all of you. These are locally nuanced solutions, and these are also national policy challenges. I'm going to toss it out to you to think about how you would work on this continuum of hyper-localized action versus national strategy. And anyone who wants to raise their hand and take that obtuse question first, jump in.
Yeah, sure. I mean, I think I would like to see national standards around prevention. I can't tell you, prevention is our biggest enemy as a drug policy advocate. We have prevention putting out messages like, don't use drugs. You don't want to be a loser. What? Don't say that. People who use drugs aren't losers. Stop that. Stop being our enemy. And we also need to see national leaders inside of the prevention space taking a broader perspective, saying things like effective drug policy is good prevention, right? I do resonate with what Elizabeth is saying, and that, you know, these things are part of preventing overdose, but so often prevention is like, to me, they feel like this elitist group where we're over here, we take care of the children, and that really fits into the political narrative of cops and politicians. Really, politicians, they say, I want to focus on prevention because that is an easy thing to do politically. They don't have to cash any chits. They don't seem weak on crime. And if we don't have prevention saying, yes, they're with us, then we seem fringy and radical. Nothing I've said is fringy and radical. There's 30 years of research around everything I say, when prevention is often spewing things that sound good, like DARE.
So if I can hop in, that's fantastic. And I want to second Devin on a couple of points. One is that we really do have to continue to have the eye on the prize of national standards. I'll just give as an example, something I've discussed with the Opioid Collaborative in the past year, which is in New York City and Staten Island, which is the wealthiest and whitest of our boroughs. We have a program called Project Hope. It's the product of collaboration between the DA's office and community activists there to systematically divert people who've been arrested on low-level drug charges from sentencing and to channel them towards drug treatment, partnering with a peer who's in recovery, a host of other services. And this organization has diverted over 50% in the past couple of years, people who have low-level drug charges from sentencing. But we don't have the same program in the South Bronx, which currently reports the largest number of overdoses, and their arrests and sentencing go on unabated. So if we just leave it up to local action, we're going to see more empowered white communities doing things to protect themselves. We're not going to see the same kind of proactive measures applied in low-income Black and brown areas that actually are actively being repressed by criminal justice agencies and things like that. So that's an argument for national standards. But on the flip side of that, I think we also need to highlight and celebrate local innovations. So the key is, and I think a lot of times it's a failure of imagination in many areas. So we need to have cross-fertilization of ideas and technology exchange. Before this panel, I just got off the phone from an evolving international network of people who are collecting data on community-based harm reduction organizations in many different countries and how they're creatively responding to COVID. And so many great ideas have come of that kind of exchange already. Actually, I want to put in a plug for National Academies of Medicine because it was really the two papers that I described that inspired this international collaboration. But the idea is to get things like what's happening in France on the radar in harm reduction centers that are part of a nationally coordinated, well-funded effort in France onto the radar of US policymakers. And then there are people who use drugs themselves who are being incredibly innovative, for example, hosting virtual safe injection. So protecting each other by being on screen where they do have access to screens. A lot of them don't have, as we've heard today. But protecting each other by watching each other digitally, watching over each other digitally. So there are so many creative solutions at many different levels that need to be highlighted and exchanged. But then we also do need a national agenda to act on those and make sure that the benefits are evenly distributed.
Great. Elizabeth wants to get in here. And then Marcus, I encourage you to jump in.
Yeah, thanks so much. So can people hear me again?
Yes.
Okay, great. So I completely agree. Absolutely need national standards. And I think we have to be really, really thoughtful about equitable distribution of resources. I guess I want to pick up on something you said though, about hyper localized. And I think, all of my professional work has been in Baltimore and Chicago. And specifically when I moved back to Chicago and started working in public health, there was a lot of pressure that we needed to be focusing on prescription opioids because of the national conversation about opioid related overdose death. But yet when we didn't have good data locally, but secondly, as we really started to publicly report on our data, what we saw is that what we had in Chicago was a largely African-American 45 to 64-year-old population who was using pretty much solely illicit opioids. As we dug deeper into the data to cross-map it with prescription drug monitoring programs, we saw that very few of these folks ever had access to prescription opioids, right? Because historically they did not have healthcare access. And even if they had, we know that there's bias in who gets prescribed opioids in the first place. And so I just say that to say I completely agree we need to have national standards, but I think one of the challenges in this space has been that people want to pick a program from name your place across the country where the drug use patterns can be really different, where the demographics can be different, where there are different sort of underlying factors, risk and protective factors. And we just see that drug use trends are really different in different parts of the country. And this is also, I would argue, equally important when we think about solutions. Solutions do need to be based on community level strengths as well as community level risks. And we need to understand what our local data shows when we're making public health plans. And yes, it's important, but I think so often we see research done in these centers of excellence, often with white communities. And it's really important that we're thinking about all those factors when we develop local plans for response.
Yeah, certainly COVID points out the importance of region, city, site specific, but you also need national guidance that is going in the right direction. Marcus, with ASTO, you're dealing a lot with local, state, federal nexus. Maybe you might want to comment on this.
Yeah, well, I really have. I mean, I think to begin with, as we've been thinking about opioids and particularly this idea of moving beyond just this treatment-oriented approach, I've really shifted to a very strong policy approach, social policy approach. And, I think we were there. And then when COVID hit, seeing these amazing discrepancies based on income, if you're poor, you're way more likely to get COVID, you're way more likely to die from it. If you're a person of color, the exact same thing. You look at who can hole up in their house and who can't. And, but we saw all of this around addiction and around the opioid. I mean, it was kind of there, flashing at what could happen. And, very little got done to address some of these underlying factors that have caused. I mean, there's been this huge increase in the number of people who are addicted. And, I don't understand that. I mean, it's not the addiction per se. It's the fact that so many people are. So I don't know. I mean, we need to deal with some of these social issues. We need to deal with a lot more equity amongst people who have access to resources and people who don't. And, I mentioned early on, I think that Trust for America's Health, there's a number of others who've begun to sort of lay out some of the policy framework, and it goes way beyond health. And I don't know what the best word is, but, this social determinants, I mean, these things are the things that make people sick. And that's where we need to put our efforts.
Yeah, this helped us to double down at the foundation on our health equity framework. I mean, we were committed, but COVID told us how important it is for us to double down and then how important that equity framing is, because for all the things you just said, Marcus, the inequity, the cost of inequity and marginality is just brought to the surface for those who hadn't seen that before in COVID. Devin, I think you had your hand up.
Yeah. One thing that I think that is happening kind of in parallel with this idea of focusing on treatment works, and the power of the treatment industrial complex is this kind of narrow idea that stigma is the problem that I find really frustrating at times. It's like, I talk to policy people, I'm like, all right, what's your policy goal? We want to bust stigma. What does that even mean? Let's be clear, the war on drugs was created to destroy Black and brown people. It ran out of dark meat and started eating white meat. And that's why we're getting pushback on war on drugs policies, because they're showing up in white communities. Stigma is not a great word, and I understand there's an academic sense around stigma, and there's all this scale of stigma, but really what we're talking about is quantified policies that discriminate against people. And when we call it stigma or something else that's nebulous, not discrimination, it becomes hard for people to really assimilate that and see how we can break that down, right? I'm not discriminated against if I'm a felon. There's a legal thing. I mean, I don't have stigma because I'm a felon. There's legal things that say, I can't vote, I can't do this, I can't do that. If I use drugs, I'm not stigmatized. I'm at risk of murder and harm by the state, right? And I think that we need to start just being more explicit. And I understand sometimes I put on a suit and I talk really nice to politicians, but I think we're in a setting like this that we can get a little bit looser and start calling things like they are, because all of the code switching I have to do on a regular basis to be an advocate, you know, I need to see other advocates also stepping outside of that thing and saying, let's say racism. Racism is the thing, right? And when I heard my co-panelists say that, that felt good, because when we're not at the national level, we're in Dubuque, Iowa, or Nebraska, or rural America, we don't hear people saying that, and that is a problem.
So important. I know we're coming to the end of our time, but these are critically important. I want to give everybody one short shot to give us your last sort of 50-second soundbite on this. But on this notion of that we need to look at the historically entrenched policies of institutions and legal structures that perpetuate these crimes of the past, racism, all the isms, and carry them forward in codified ways, one has to tackle that. As a core driver of the kinds of things that we're seeing. And I agree with you, Devin, one needs to see stigma or any perception of a person's life conditions in that broader context. So quick hitting 30 seconds from everybody of things you want to make sure our listening audience takes with them. And I'll just go around my Hollywood squares, which is Marcus first.
Well, I'll be fairly quick with this, you know, and not that everything's about COVID, but that's what we're living right now. And I mean, it's, I mean, you know, I think everybody in this panel knew about the kinds of things that were, I don't think anybody in this panel is probably that surprised at what happened around race and socioeconomic class with COVID. But if this didn't get the attention of the public, then I don't know what's going to, and I think it did. And so I think the time we have, and this is a very bad situation we're in, but one of the good things about it is we have the opportunity to use this to try to address some of these things, and I hope we will. And again, I think we have to address some big societal policy issues, and I think local work is very important, but it's time to fix some stuff that is affecting people in all kinds of communities. And if we don't do it now, I just don't know when we ever will.
Okay. Helena?
I'm going to try to squeeze in 2 points. One is along lines of racism and power inequalities. This may be cynical, but I think that some people who really buy into a racist structure may not be either surprised or disappointed about the inequalities in COVID deaths or the growing inequalities in opioid deaths. This is a very tall order, but it's opioid crisis opens up a window on how whites are hurt by structural racism. And I think we have to continue to come back to how white people are hurt by racism and affluent people are hurt by social inequalities. There are studies showing that the life expectancy of affluent people is lower in highly socially unequal societies. There is a cost to it. Then the second thing is, and this is back to a point Elizabeth raised about how we can't have a one-size-fits-all policy response. I thoroughly agree. I think one thing I want to bring out about the example of the AIDS activists that I highlighted is the degree to which direct engagement of the people affected by opioid deaths is critically important, because that way we get to creatively tailor responses in local areas, feed the democratic process, and in that way also contribute to social determinants of health, positive health outcomes, by strengthening community participation and ability to act on one's own well-being. So community engagement and representation in the process of setting these health policies, particularly among people who use drugs, is going to be critical. Thank you.
Great. Thank you. Devin?
Yes. If you are a person of privilege that at home sits on the local opioid task force, be willing and able and eager to give up your seat to a person in recovery that uses drugs. That's an explicit way to do what Helena just said. Number two, if you are on this webinar today, you actually know more about drug policy than 99% of politicians in your state legislature. It is on you to be civically engaged. My state legislator knows who I am. When I walk into his office, he's like, shit, Devin's here again. He wants to talk to me. It should be the same way. And at the same time, he calls me when there is a legislative issue that's around drugs and alcohol. You are an expert. It's on you to be the key informant for your elected official. If you're not doing it, you are part of the problem and complicit. Thank you very much.
Okay, Elizabeth, take us home.
So I want to thank everyone else for calling us to action, because I actually just want to close with a question that I struggle with a lot. So if anyone has suggestions or solutions, I would love to hear them. But I think, when I think about social determinants of health and racism, and as Alonzo put it, all the isms, and how they apply to the opioid crisis or to COVID, I think one of the things that comes up is if we really try to get to the causes of the causes, what I hear back in response, having worked for government, is like, oh, well, we could never, say that living wage is a response to the opioid crisis, or we could never say that like this thing is a response. It's too big, that we aren't going to see results in this election cycle. It's never going to happen. And so one of the things I spend a lot of time thinking about is like, how do we frame, we all recognize that there would be tremendous positive outcomes with regard to the opioid crisis, with regard, like in so many avenues and areas of life, including but not limited to health outcomes. So how do we get enough political momentum behind these issues that we all know matter so much, and as Helena put, would have a really positive cumulative impact on our broader society? But how do we get enough political will to be able to do these things that we know matter so much, but may not be able to be measured on a positive impact with one particular outcome in the course of one election cycle? And that's often what we're up against in the world of policy. So I would just encourage people to think about that in addition to the calls to action we heard from other panelists, and I want to say thanks for letting me be here today.
Well, thanks for everyone. We could go on for another hour. I can assure you, as the co-chair of the working group on these issues, we will jump off from this presentation and recommit and redefine the work of that subcommittee to incorporate the questions that you've left us with in the information that you've shared. So thank all my co-presenters, all the listeners that have stayed on, and I'm going to turn it back to Liz.
Thanks so much, Alonzo, and thanks to all of our terrific panelists. I think that you've given us a lot to think about over the next couple of days and weeks, certainly as the Action Collaborative reconvenes. So thank you all for your terrific presentations and discussion. We're now going to take a short break, and we'll return with our final session at 3:40 p.m. Eastern.